Well, we're happy to have you. And since it's
Yeah.
10, I think we ought to get started.
Yes.
So I'm just going to go through a preliminaries. Welcome to the Audio-Vestibular Medicine case discussions. And this is our live event, which we will record for YouTube. We have monthly presentations of interesting cases in audiovestibular medicine. I am one of the hosts, Gerard Gianoli, along with Mohamed, Hamid, and Eugen Ionescu, but everybody's encouraged to participate. We have information discussed here is meant solely for educational purposes and not intended as medical advice for any individual. For individual medical advice, please seek the counsel of your own physician. While these conferences are geared toward medical professional, patients are welcome. However, we will not discuss individual patient cases in this setting. Please speak to your own physician for individualized medical care. As I mentioned, we're archiving these discussions on our YouTube website, which the address is listed here. And for today, we have a special guest presenter, Dr. Art Mallinson, and he is from the University of British Columbia, and he is going to talk to us today about decompensation. What does that mean? And I'm going to hand over my screen to Art, who can share his screen and start our discussion.
Okay. Thanks a lot, Jerry. It's going to push this button here and see if this works out. Hopefully it will. And there you go. And you.
Beautiful.
Okay.
That's it.
Okay. That's great. Now, quick introduction. I spent 40 years in a tertiary care big city hospital neurology unit diagnosing complex vestibular patients. Today, I'd like to talk about a certain category of patient that we maybe all be familiar with. Let's start off with a general discussion and then zero in on a specific case report which illustrates the situation. The diagnosticians in the audience will be familiar with many of the points I make, but it's important to outline the difficulties of dealing with complex patients, many of whom do not follow the course that the textbooks outline. And quite often I tell the patients, they say, you're weird. By weird, I mean different than written in the medical books. Since I'm not a medical doctor, I don't have access to radiology or other diagnostic hospital tests that were carried out in patients. But I hope it will become clear in today's talk that these assessments are often not necessary in arriving at a diagnostic conclusion. I don't think it's a revelation that some of the patients we see just don't get better. And we ask this question to ourselves quite often. Why won't my patient get better? We're often left with a situation where the patient, the clinician, and the rehab experts are all perplexed because we all hear the same story. Oh, I've just plateaued. I'm not getting any better. Why won't my patient get better? Well, before we start, let's get this out of the way. I'm Canadian. Canadians have a worldwide reputation of always apologizing. Every time they open their mouths, they say they're sorry. So let's get that out there. I'm sorry. I'm not going to be able to answer this question for you today. But I do want to create an environment where we can all discuss our feelings and thoughts about these complex patients. If your excitement level has already started to decline, then you are not alone. Poorly understood areas can be fascinating and challenging, but can also cause some frustration. There are certain clinicians who have a reduced desire, shall we say, to pursue this subject matter. There can be few physicians so dedicated to their art that they do not experience a slight decline in spirits on learning that their patient's complaint is of dizziness. This frequently means that after exhaustive inquiry, it will still not be entirely clear what it is that the patient feels wrong, and even less so, why he feels it. In other words, you've got to spend all this time with the patient. There's a small chance you might be able to figure out what they've got. There's even less chance you'll be able to understand why. So this reduced desire stems from the fact that there's no guarantee you're going to be able to figure this out. Dr. Matthews was one of the most respected neurologists of the 20th century, and he wrote this sort of definitive textbook in 1963. So let's all keep that in mind. Okay, Here's the case report. Mr. Smith has been referred to his ENT doctor because of his complaints. He sat down and is starting to relate his story. Doctor, when I roll over to the right in bed, I get dizzy for 15 seconds and, oh, stop right there, Mr. Smith. Thanks. I can stop you. I don't have to hear any more. He's already got Mr. Smith diagnosed and has already planned his management. What you've got is called BPV. Don't worry, I can fix you. Nurse, next patient, please. Dr. Jones has committed 45 seconds to seeing this patient. I hope everyone has enjoyed my case report about Mr. Smith. Thank you very much. No, I'm not finished yet. Needless to say, this is just a fictitious scenario that I have invented. The point I'm making is that because Dr. Jones didn't take a complete history, he may have unwittingly invented a fictitious patient. He's used an anchoring bias. Anchoring bias is, yeah, told me all I need to hear. I don't have to hear anything else about your story. And his overconfidence, I'm not going to listen to your story anyway because I'm the world expert. I've been doing this forever. I don't need to listen because I've heard it all. So this may have misguided him to an erroneous diagnosis and quite possibly also created a frustrated patient who is given no chance to describe all of his patients, all of his complaints. So we've got to keep this in mind. And again, I don't think I have to tell people this, but it's something we need to keep in mind. Of course, today's talk is not going to discuss anything about the legal system, but there are some points from this legal doctrine called natural justice that we do need to remember when we're assessing a patient. Not necessarily a medical legal patient, any patient. A patient must be given an adequate opportunity to present their case. In addition, the assessor must be unbiased, so you cannot jump to a conclusion based on your past experience. You're not allowed to do that. As I tell medical students, when a patient comes in, number one, sit down. Number two, shut your mouth. Number three, listen to the patient's whole story. And I tell them, if you can remember these three things by the end of our session today, then that's just great. As we illustrated in our fictitious case, the complete history must be taken and then utilized in order to come up with an accurate diagnosis. You cannot cut a patient short. You cannot edit what they have told you. If you use a confirmation bias, you might decide that your patient probably has BPV. You will then accept any part of the patient's history which supports your theory and disregard any part of the patient's history which goes against your story. As I mentioned before, I probably don't have to go over this, but I wanted to outline how important it is for a diagnostician to keep this in mind. Okay, here's our actual patient. RP, he is unable to work. He's 60 years old. He's still relatively fit otherwise. He was on short-term disability because of his problems until the disability ran out. Then he applied for LTD. His LTD carrier denied him further coverage. Says, you're not disabled. He's now seeking legal action to fight this decision. Sometimes we refer to these patients as the walking wounded. It's a term that people have probably heard before. Why is this patient unable to work? I was asked by his lawyer to address exactly this question. Part of those requirements by me were to address which aspects of his job. In other words, what parts of his job can't he do? He's not a house painter. Doesn't have to go up ladders. He's not a roofer. Doesn't have to, walk around on unstable surfaces all day long. He's not a forest warden. He is not required to carry out strenuous physical activity at all. He's an insurance adjuster who has to assess claims and produce reports. He has to drive to claim sites and assess if a place has been burned out by a fire or something. He has to conduct the on-site assessments. He has to climb around and have a look at things. And he has to carry out and sort of be in charge of all the investigations that have to take place. His insurance claim assessments involve interacting with people in public places, talking to lots of people in groups on a site, carrying out on-site inspections, and discussions with interested parties, different, whether they're other insurance agents or police or firemen, whatever. In addition, when he's in the office, he sometimes has to participate in Zoom calls with other people involved in the claim. For people like us, it's no big deal. But if you are involved in a Zoom call and you're having trouble, you have to change your look around and look here and look here and look here. He has 2 huge computer screens in front of him in his office, and he has to scroll back and forth on each screen, on this screen and on this screen. So that's that's sort of his job that he is required to carry out. Okay, let's take an in-depth history. Remember, I've taken in-depth history to find out what's going on. A lot of the books say, history is 90% of the diagnosis of a vestibular patient. I was actually in court a couple of weeks ago, and I had to say exactly that. Of course, my history starts off with, when did your present complaints begin? Totally appropriate beginning. In March 2020, he underwent neck surgery for 2 herniated discs. As mentioned, I don't have access to any of these MRI studies, but he did have substantial cervical spine pathology. It was assessed that he needed a discectomy, and he also needed a fusion. Fortunately, the surgery was reasonably quite successful. Although I didn't have medical details, he was told he had some vasovagal compromise post-surgery. I think he had fluctuating blood pressure and some other minor symptoms. But the symptoms settled successfully over a period of a couple of months. A few months after this, apparently unrelated, he developed dizziness. Now, I don't accept the word dizziness with an explanation. I don't think any of us do. We went into some more detail. I don't even accept the word vertigo. I mean, we've got some international audience here. Vertigo means spinning. If you haven't got spinning, you haven't got vertigo. I have to finish my sentence. In North America. In Europe and Asia, quite often people describe, being on the 85th floor of an apartment and looking down. In Asia, that's called physiological height vertigo. So maybe we have a 25% of our population don't speak any English, just have a few words of English, and they maybe just have immigrated from, say, Europe or Asia. So if a patient comes in and says, "Hello, I have vertigo," and I write down, "This patient complains of spinning," I may have invented a fictitious patient. So I don't accept the word dizziness. I don't accept the word vertigo. Say, "What do you mean? Tell me what it feels like." He describes spinning, nausea, and swimming. The nausea was constant, and he also noticed that, or his wife noticed, that when he was in the hall at home, he would veer off to the left. He also had these balance issues. He noticed the balance issues himself. He emphasized that he was off balance on a constant basis. He outlined how unusual this was. I talked about firefighter. He used to be a firefighter. I'd scramble up a 100-foot ladder, no problem at all. It was totally comfortable if I had to go up there. Now, I'm unsteady on any ladder at all. I don't even like to get on a step stool in the kitchen to reach something on a high cupboard. Definitely different than they were before. Even when I go out grocery shopping, I like to lean on the buggy. Well, full disclosure, I like to lean on the buggy as well when I go grocery shopping. It's because I'm lazy and I can just lean on the buggy. But this was something he commented on and said that was totally different than it was before. In addition to these classic complaints, he also volunteered several symptoms that are regarded in the literature suggesting otolithic pathology. He can't scroll on his laptop anymore. Can't scroll on his phone. Can't even look on his phone and his apps on his phone. Can't watch. He loved hockey. He can't watch. Canadians love hockey. He can't watch hockey on TV. He can't stand being in grocery stores because he has to look on the shelves and people rushing past him. He can't stand that at all. He can't stand driving in the rain because of the windshield wipers make him horrible feeling and nauseated. In the snow, it's absolutely terrible because the snow coming at the windshield is even worse. The symptom set is referred to with several different terms, such as, visual vestibular mismatch is the one I'm partial to. It's also been upgraded to PPPD now, which is again recognized as a symptom set. These are complaints I hear, these complaints we hear repeatedly, I'm quite sure. They're strongly suggestive of a vestibular impairment. He also emphasized, yes.
He never had these symptoms before his prior neck surgery.
No, not at all. That was one thing I was wondering. Okay, well, something, but no, this didn't start until quite a few months after my neck surgery had all resolved and I was all better. Okay. All of a sudden, this started. Yeah, so good point, and I should have emphasized that. Thanks, Mo. He also emphasized the story has been exactly the same for 4.5 years. If you talked to me a year ago, you would have got exactly the same story. If you talked to me 2 years ago, you would have got exactly the same story. His family doctor sent him to see an ENT. The ENT listened to his story to a certain extent and said, this probably isn't BPV. Well, okay, great, thanks. Sent him for a vestibular assessment and therapy. So to me, this sounds as if it was a polite way of telling the patient, oh, I don't know what you got. Probably something, but I don't know what you got. I have the result of these vestibular assessments he had, and we're going to be discussing those in quite a bit of detail in a few minutes. Okay, so what do we got here? We got a patient here. I hope everybody can accept the fact that these complaints are legitimate and sound vestibular. Let's go through the possible diagnoses. I think we can agree with the ENT doctor that this is not BPV.
Vestibular. One second.
Yes.
Art, I may have missed it, but you mentioned spinning, but are these episodes of spinning or constant feeling of spinning, and how long do they last? And
it is constant. It's virtually constant. He emphasized everything he's got is constant.
Okay.
Just not changing at all.
And the initial onset's no different than where he is now.
That's right. He emphasized, God, I haven't changed in 4.5 years. He told me five or six times. 4.5 years, I haven't changed at all.
Okay.
So, has he got vestibular migraine? No, by definition, he does not have vestibular migraine. Vestibular migraine, by definition, is episodes. And again, I was actually in court about this as well. Somebody was diagnosed with vestibular migraine, and I stood up and said exactly that. It was a similar patient to this. This patient is constant, so they do not have vestibular migraine. Again, I don't diagnose migraine, but if the patient has vestibular migraine, they also have something else because they don't have recurring stories. This is not typical story of a labyrinthitis where something comes on and gradually resolves. It just isn't a labyrinthitis because of the persistent nausea, the persistent imbalance. It's not psychiatric disease. Again, I'm not a psychiatrist, but some of the world experts, like Dr. Staub at the Mayo Clinic, has outlined psychiatric disease does not cause nausea or imbalance. It just doesn't. We must remember this is a medical legal situation, so we need to keep that aspect in mind as well. However, the patient is, I think you'll agree, the patient is definitely telling a legitimate vestibular story. It didn't strike me as one that was being made up. Patients who are malingering or trying to impress the clinician that there's something terribly wrong with them. They don't volunteer. This is volunteer. I wasn't asked. He wasn't asked. He volunteered that he can't stand driving in the rain or he can't watch hockey on TV. Now, if you're trying to make up a story to get LTD, you don't go to the doctor and say, oh, I can't watch hockey on TV anymore. You don't say that. It struck me that this was a story strongly suggestive of peripheral vestibular pathology. Okay, great. I think Jerry sort of alluded to this as well. He emphasized there's been no change in 4.5 years. Okay, now a lot of the books say if it's not getting better, you're not recovering the way you're supposed to. It's central. This may make us think about central. Mo?
It's very unusual for a vestibular disease not to exhibit some changes over time.
Yeah, I agree with you. I totally agree. So again, if it's not vestibular disease, what can we say? What can we say about this? Maybe it's central. He was recently seen by a neurologist who could find nothing wrong at all. Basically said, no, it's not my patient.
I take an issue with that. Neurologists are not vestibular physicians, and
You're correct.
Their exams don't really include any detailed vestibular exam, despite the fact that the patient is complaining of dizziness. But go ahead.
I
and
totally agree.
Did not have any hearing issues at all.
No, hearing was normal.
Okay.
Which is reasonable for a 60-year-old male. So I agree with you. That's fine. But what I can say, there's nothing sort of central along in the brain stem pathways. There's no evidence of lesion anywhere in the brain stem pathways. And so the bad stuff, shall we say, has been ruled out by the neurologist. So the point I'm making is we have, I think, a legitimate sounding patient. The only weird thing, they're not getting better the way they're supposed to.
Is this 98% or 100%
Okay, debatable. So here's a prime question we have to try and need to answer. Our patient has plateaued for 4 years. A long-term disability corporation is asking for answers. What's going on? That's all I say. Am I missing something? Is there something I've missed in this patient's history and this patient's sort of assessment? Here's the slide I showed a few minutes ago, and I have bolded and emphasized the very, very last part. As it turns out, if this patient's story that I've told you was the whole story, then I could be accused of not practicing natural justice. All history must be considered. In actual fact, when I was assessing this patient, I did keep the tenets of natural justice in mind. I didn't say, when did your present complaints start? When I took my history, I went back to the onset of his complaints, not the onset of his present complaints. When's the first time you ever had any problems? So now I'm going to tell you the rest of the story. It turns out this patient suffered a similar acute attack 5 years before, in 2015. At that time, he complained of constant spinning and nausea. He was also extremely off balance, and this persisted for 3 months. Again, we have an in-depth assessment, which sounds as if it was a polite way of telling the patient this, well, it's possibly BPV. That's what he was told back then. He was sent on for vestibular therapy. He saw 4 different vestibular therapists at that time. Again, this is 2015.
Okay. I take it that the GP didn't do vestibular exam. The ENT definitely did not do a vestibular exam. So
quite possibly.
In his history, had there been any physician that did a vestibular exam on this patient?
Not really. He went to the ENT who said, yeah, you probably got BPV. It's probably going to get better. Don't worry.
Okay.
So he had spinning, imbalance, nausea, and he said complained of the feeling like walking on pillows. You know, those blow up castles at the fairground ride. You go, I feel like I'm walking on those. So I think we can agree here. This is a classic, probably unilateral episode from somewhere in the balance system. Unilateral because it's spinning. If you have bilateral pathology, you don't spin. So I think we can say in 2015, he suffered a vestibular episode. Okay, what happened to the patient back then? He said they were constant for 3 months. He gradually improved over the next 9 months. And by the 1-year mark, he was essentially symptom-free. So I think all of the diagnostic clinicians, probably any therapists here as well, will agree with the fact that this is a hallmark sign of compensation for, rather than recovery from, an acute vestibular episode. So if it had gotten better over like 4 days, then that's not compensation, that's recovery. So he probably was left with something and for which he compensated. So that's good. Again, you say, well, don't worry, it's probably going to get better. It does get better because he compensated. Good.
Was he able to work during that episode?
During his initial episode, no, he had to take a certain amount of time off work. He had to take 2 or 3 months off work. So it was a little bit prolonged. It wouldn't have been that long, I wouldn't have thought, but he did get better. He gradually improved. I think we can also agree that his more recent episode was also vestibular in nature. However, what is perplexing is that there has been no change whatsoever. So in other words, 2 episodes, we can agree they've both been similar. What's happened? How come this second one isn't behaving the way the first one did? As I mentioned, sometimes it might take further digging to extract a remote history. In this presentation, we observed this patient's successful recovery from his initial attack. After a year, he was just fine again, on with his life. So what's going on now? In an elegant plenary lecture by Joe Furman at the Bharani Society meeting in Korea, he outlined the concept of decompensation, which is going to be required if a patient suffers a subsequent attack. This must be followed up by a so-called recompensation. In other words, you have to once again learn the new situation. You have to unlearn what you knew and then relearn the new situation. This has been shown to be much more difficult than the standard compensation process. Of course, this will be true if the second lesion caused contralateral damage, because now you've got 2 airplane engines that aren't working, but it's also been shown that repeated ipsilateral insults are still difficult to cope with. Patients like this are often seen, this is a situation I see all the time, very, very commonly. They give recent histories, mild spell of spinning lasting a few hours with a bit of nausea, but it's not really in keeping with their incapacitation and their chronic complaints. I'm not getting better at all. So you have to dig out that they had an acute spell years and years ago and now have suffered a decompensation. This process is extremely poorly understood, but it's often quite a challenge.
And I would add a little bit here.
Please do.
Yeah, can you hear me?
Mm-hmm.
All right. Yep. With all due respect to Joe Furman, who is obviously a good vestibular physician, this process implies that the first episode and the second episode are not from the same side. Correct?
That is, it can be if you're left with the first episode, which causes a little bit of damage but doesn't completely wipe you out on one side, then you can have a second ipsilateral episode. But you're right. It does suggest that it is a contralateral problem. You had a lesion in one ear, or a vestibulopathy, shall we say, in one ear. Then you were unlucky enough to have vestibulopathy contralaterally. I remember when Joe gave this lecture, I went and asked him afterwards. I said, "Okay, you're a neurologist. decompensation, is that because it's neurological damage, or is that because it's further vestibular damage that you're having trouble coping with? And your point taken, he's not an ENT doctor, but he said he thought it was further vestibular damage that you have trouble coping with.
Okay. The problem here is we don't know which side was responsible for the first episode in your patient. And the second is we really don't know what's the second episode is coming from. But carry on.
Right.
Very interesting case. Go ahead.
Okay. I haven't.
I just want to make a comment. My definitions are a tiny bit different than yours, in that I think of decompensation not a new vestibular injury, but sort of the brain forgetting how it had compensated. Whereas what you're presenting here, I think of as a new vestibular injury, and he's got to compensate again.
Yes.
So this is more recompensation rather than decompensation.
Yes. Okay. Yes. Thank you. Thanks for clarifying that. But you're absolutely right. Patients have something, they all of a sudden start to stagger around because they're 75 years old and say, well, and then they had an acute attack when they were 25. Their 25-year-old cerebellum did a really good job of compensating. Now they're 75. They have, like you say, they're starting to decompensate because the 75-year-old cerebellum isn't working quite as well. I think, and Mo, thanks for your comments. I'm going to show you the results in a couple of minutes to try and find out what's going on. I think we've got some more clarification. But a point I'm making, we're now left with a diagnostic challenge. I don't know what the hell's going on, and a frustrated patient. Frustrated patient, frustrated clinician. This can degenerate into a situation where patient thinks that doctors aren't believing them. This can sometimes lead to a patient not being believed by acquaintances, colleagues, family members, long-term disability providers, whatever. So it can be a real problem all around. The patient isn't resolving in a characteristic manner that's outlined in the textbooks. The books say, and they get onto the internet, they get onto the books. The books say I'm supposed to get better. That's correct. The doctors say I should get better. That's correct. Especially if there's medical legal implications. Well, I'm not making this up. Sometimes psychiatric referrals are attempted. And if you send a patient to a psychiatrist, there's not a stigma attached to that. If for instance, if I'd been 5 minutes late today, I said, well, sorry, I was in an appointment of my orthopedic surgeons. People would say, oh yeah, nice to see you, Art, thanks. If I said, look, I'm late because I had an appointment with my psychiatrist today, people might say, having trouble with stress, Art? So there should not be a stigma attached to that, but there is a stigma attached to that. If you refer a patient to a psychiatrist, the patient's going to think either that you don't believe them or you do believe them and you think they're crazy. So, and you go to the therapist doesn't understand. Well, they've read all the fancy books and have seen all the things. We got a couple of therapists here. My therapist doesn't understand why I'm not improving. Maybe the therapist thinks you're not cooperating and not doing the exercises at home properly that you were shown. So patients do not feel legitimized, and they can run the risk of having their professional careers ruined, their social life markedly compromised. My friends won't believe me. They don't know why I don't want to go dancing anymore. Their recreational activities curtailed. I used to love playing squash, and I can't hardly stand on the court anymore. Needless to say, this can make a patient feel quite hopeless.
Okay. By the way, the therapists are correct, because the therapists know very well how to do maneuvers.
Right.
Mostly the aptly, sometimes Simon, but nothing else.
Right.
So they're correct. They're not neurophysiologists. So I think the patient is needing more workup. Carry on.
Yes. Okay. I told you before the patient did have some diagnostic testing. Let's have a look at it. It was quite helpful. It actually supports this poor patient's failure to recover. Head impulse testing has documented that there's some right-sided pathology. Look at some right-sided pathology right here. This fits with a history of an acute vestibular attack. From the patient's history, I think we can also agree that there's some otolithic involvement. If you say I can't stand windshield wipers, it is in the literature that is a definition almost of an otolithic patient. So now we've got right-sided pathology here. Okay, I haven't shown you the whole thing. Here's the rest of the assessment. There are also some left-sided abnormalities.
Yeah.
Again, suggestive of an acute unilateral attack. So now we've got some diagnostic testing. I mean, I totally disagree with my theories in that, but this does support my theory of two separate vestibular events separated in place, one on the right, one on the left, and separated in time, 5 years apart. So perhaps the whole concept of compensation, decompensation, recompensation, however we want to term it, should be rethought. Compensation implies that a patient will learn to cope with a deficit to the point where they can resume their normal lives. So if you tell a patient you're going to compensate, patient might say, well, God, am I going to be perfect? You can say, well, no, hopefully we'll get to the point where it's not going to impact your normal life, whatever your normal life is. If you were a star acrobat on the acrobatic team, or a star performer of Cirque du Soleil, I don't know if you know Cirque du Soleil or not, you would lose your job. If you were a sort of professional unicyclist, you would lose your job, because a professional unicyclist has to have perfect balance, not well-compensated balance. But we know this progression does not sometimes take place to a satisfactory level. These patients are left with persistent complaints. So in this case, we've listened to the patient's complete history right from the get-go. We've tried to come up with a reasonable diagnosis. As I said, a gradual recovery over a period of time, of weeks, maybe months, is classically suggestive of compensated vestibular pathology. So this guy had an attack in 2015. He compensated effectively for it, because he said, after a year, I was fine. By which he means I did not have there was no impact on my daily life. Now, thanks to Dr. Furman, perhaps now we have an explanation for what's going on. It says crucial, especially given the medical legal aspects of this case. So let's go back to this patient's history. First attack, an acute vestibular event. He compensated effectively. After attack number 2, we all agreed I think that he's suffered another acute vestibular event, and he said it is sort of the same as the first one I had. He sort of volunteered that. Unilateral pathology, once again suggested. However, this time he's going to have to decompensate and recompensate. Again, by decompensate, I mean forget about what you've been practicing for the last 5 years and relearn it in a new way. Given the challenge that this process is, he quite possibly may be left with lingering complaints. The important point to make is these complaints are not psychiatric, they're not made up, they're probably not central, but these complaints, this symptom set must be regarded as being of peripheral vestibular origin. But for the vestibular lesion, he would not be suffering these complaints. So what are we left with? It's important to understand that this compensation process may not take place to a satisfactory level. These patients are left with persistent complaints. What can we offer them? The important thing for the clinician to understand, these patients can often benefit from just being listened to. He sat down and listened to my whole story. Legitimized, told me he believed me and that I actually had something wrong. And reassured that 2 things. First of all, they have real disease and they don't have anything awful or nasty or horrible. Again, is it central? And I'm not a neurologist, but central, the neurologist will say, if you've got something which is exactly the same and not fluctuating, it probably is not as a result of a central lesion. So, but we're often left with a frustrated patient a frustrated healthcare team. If other causes have been ruled out successfully, again, you have to regard these complaints as being of peripheral vestibular origin. So, ENT doctor, it is your job to cope with this. What are you going to do? Unfortunately, it's often all the clinician can offer, but quite often it is of extreme benefit to everyone involved. If you worry about it, it will make it worse, given that you the sort of autonomic responses. If you worry about it, it will make it worse, which makes you worry about it more, which makes it worse. And you keep going back to see the doctor once a month to try and find out if there's anything new. If the doctor says, no, I don't know, I don't know anything, then you say, well, why don't you go to the library? Well, years ago, you used to go to the library and read journals. Why don't you go read a journal? If the doctor says, I believe you, it is not well understood what's going on, then it implies that you actually do care. You actually did read a journal and you've tried to keep up with literature. And unfortunately, the literature doesn't really understand what's going on very well. But this is all you can offer the patient quite often. But quite often it is of extreme benefit to everyone involved. And the diagnosis can often be therapeutic because you told the patient what is wrong and what is not wrong, and it makes them feel better. Quite often, that is all that you can offer, but that's all they need. So thanks for going through this study with me, this case study, and hopefully this makes sense. And Mo told me he was worried I had so many slides, so I told him I was very, very good at talking fast, so hopefully I've wrapped it up in appropriate time. We've got lots of time to talk about things.
You hopefully did great. You did great. I tell you, I would... I have to admit that when someone says they have constant spinning, I find most of the time when I really push them, what you find is if they're still, they're not spinning. It's only when they're moving do they know the spinning sensation, which I think more points to a peripheral cause, whereas
that's a good point. People move around. I mean, I'm moving around a little bit now. You're right. Sit entirely still. I don't have it in your life. You don't really sit entirely still so much. So I agree with you. They say it's constant. If you really push them, it's actually not constant. It's constant anytime they move their head, which they do 500 times a day.
Yeah. Now, if you really think about it, we move our heads a whole lot. We really do. The other thing too is, I will say the one thing that really bothers me about this case is we don't really have a medical diagnosis as to what the heck happened to this guy, and there's no guarantee it's not going to happen again tomorrow, depending on what it is. We had I was telling you earlier, we just had the ANS fall meeting, and I chaired the vestibular disorder section, and we had a really interesting case of vascular occlusion causing an acute peripheral vestibular syndrome, in one case that got both ears. And it was very nicely presented. And in a situation like that, it's good to know, because not only can you help prevent another vestibular disorder, but that's somebody who's at risk for a stroke and more significant pathology and death. I do think, this is somebody I would do a very extensive evaluation. Not that he's had that many episodes, but the 2 episodes he had were just life-altering over the course of multiple years.
Oh, that's fine. I didn't have access to too much of, because I was asked to focus by the lawyer. I was asked by the lawyer rather than the physician to focus on what was going on from a vestibular point of view. So this is what you sort of have to zero in. If I had commented on something like that, the lawyers might have said, "Oh, gee, didn't know you were a cardiologist, didn't know you were a vascular surgeon." So you have to focus in on that. But your point's well taken. Again, the terminology is so hard. Sometimes people say, one of my colleagues in Toronto, John Rutka, basically said, "Well, just call it acute vestibulopathy if you've had it once, and if you've had more than one, that's recurrent vestibula.
Right.
So there, thanks. That's what you've got. Thank you very much.
Yeah. Jerry and Jean and that matter, recurrent vestibular neuritis or neuritis is commonly is on the same side. So we have a little bit of a problem here.
Yeah.
Even though the first, hang on, Art, let me finish my comment, please. The first episode, yes, clearly it is a vestibular neuritis, but we don't have any vestibular testing to document which side. And frankly, using the VHIT only without caloric testing is a major mistake. So I don't know. I don't know what you feel, Jerry, from a clinical point of view, or Eugene.
Jerry?
Yeah.
Well, it's like I said, this is somebody I'd go over with a fine-tooth comb looking for something because of the magnitude of the burden of symptoms on this fella. We know he had 2 severe episodes, but we also, don't know if he's had maybe some little minor ones that he's forgotten about. So when I think of patients who present to me with the symptoms of an uncompensated or decompensated vestibular lesion, the things that go through my mind are, one, is there a problem with the brain preventing compensation? 2, are there medications suppressing the compensation? And 3, which is probably the more common one, is a fluctuating vestibular lesion or multiple vestibular hits. And then I would also add the 4th one is sort of a psychiatric. It's not really psychiatric, but patients who avoid moving in certain ways because of the significant symptoms, to where they get uncompensation because they do not move to be able to compensate. So that's kind of the 4 things I think about. And of course,
that last point you made is very, very important. You see some patients who haven't gotten compensated. Well, what have you been doing? Well, I don't do anything. What happens if you move? Well, I don't move my head, because if I move my head, I feel funny. So I don't move my head. I just sit in my chair all day long. So again, like you say, that is the total, uncompensation or decompensated, whatever you want to call it.
Interesting. I have one lady who is, I think, 39 years old right now. And I first met her about 6-7 years ago. She had really, really bad BPPV with panic attacks associated with them. And she got them when she was 16 years old. And from 16 years old to when I met her, she refused to lay flat to sleep at night. And now that it's all gone, she still will not lay flat at night, and she's told me, it's just, I don't even want to take the chance, is what she says, and it just shows you how so many folks, they'll practice trigger avoidance to the extreme, to where they won't compensate sometimes.
One comment about, okay, yes, please, Morgan.
Oh, good morning. I was just wondering what you all thought about maybe this decompensation coming from after his neck surgery, 3 months prior to the onset of this, persistent dizziness, with maybe that vestibular spinal reflex being infiltrated during that surgery. I don't know if you had
actually, Morgan, when Art was presenting, that was the first thing I thought of. Oh, is it from the surgery? But I think the
delay
is long enough that it's probably not related to the surgery. Because you said four months later or so.
Yeah, he definitely said it was a few months later, like you said, Jerry. Yeah. And I would have thought if it was a cervical spinal thing, it would have caused imbalance, quite possibly nausea. But he definitely volunteered. He was spinning and spinning and spinning, which involves some VOR aspects of it. So I would have thought. But yeah, your point saying, it's one thing you do have to keep in mind for sure.
But, again, along with Morgan's comment, I basically tell all of my patients, if you have surgery, be prepared for decompensation. I mean, I don't care if it's spine or gallbladder or whatever.
Sure.
Any kind of physical stressor to the body can lead to decompensation. And I just kind of tell them, look, you're going to need to be prepared for that. It doesn't mean there's something new going on. It's just your brain is just kind of overwhelmed and wants to do things the old way, if you would.
Yeah. Oh, important point. Yeah.
Yeah, and
I
part of
think
in
it's
our
typically immediately afterwards.
yeah. In our therapeutic rehab protocols, oftentimes we do a lot of proprioception, a lot of ensuring, like maybe over those 4 months he wasn't moving as freely just because the surgeon told him not to move, but that would be somewhere I would explore.
Oh, absolutely.
I think Bullet, do you have a comment?
Yes, I do. I mean, thank you. That was fantastic. I learned new thing. That's a very nice concept. And my understanding is decompensation means to forget. And then recompense, but probably might not be very easy. But then build on the new techniques, new maybe exercises like visual exercises or optokinetic. So reframe it. That's a very good idea to the therapist. I definitely would like to share it in there. My issue is when the patients come in here, I diagnose them as the term that sounds like you hate it, vestibular migraine, which also you mentioned that it's a cortical disease. Why the heck is this is here? And this is our previous conversation with Gerard too. How come is this? I mean, cortical disease, we are talking, and then it's evolved into the CSF thing in there. But I still call these people as vestibular migraine, but tell the patients that this is a term that for us to understand overall your symptomatology, it doesn't mean that, and it's very confusing on that part. So you mentioned about this starting with this, this looks like a total issue when you're describing the patient, but then when your tests are done, you see semicircular canal deficiencies, a defect, and then you redo those things in there. So isn't this comes to the same point of vestibular migraine and Cohen's and Randolph and Robinson teachings, where the velocity storage is combat progressed, and then you are kind of try to re-stiffen it or re-shorten it. I'd like to hear your ideas about these things, because we work in all with the Gerard and the others too. What can we write about? How can we link this so-called peripheral disorder and then against the cortical? So again, thank you.
Yep. I think these are good points, but if we look at vestibular migraine, doesn't really meet the criteria. Number two, the idea of the velocity storage is good, but we don't have any objective documentation of the velocity storage of this patient. I think this patient needs more thorough vestibular evaluation. Definitely, I would like to see the caloric tests.
Oh, I totally agree. Yeah.
Especially the ice water in the prone and supine positions.
He'll love you, Mo.
Yeah, that's what it is.
Actually, the rotating chair test, because if your latency is abnormal, then we can argue that the velocity storage is involved here.
Yeah.
Eugene, we didn't hear anything from you, Eugene.
Thank you very much. It's very nice case report, Art, and this recall me some similar cases. So the first, I must agree that I think that I think that was and the first time when the patient was symptomatic, maybe I made only on this video head impulse test, I think that maybe it was an inferior neuronitis or an difficult to see, but I think at an inferior vestibular neuronitis, and the second time maybe the similar, or if not, a differential diagnosis with an eventually with an bilateral vestibulopathy, progressive vestibulopathy. Even for the instant, I understand that was only the patient experienced only two episodes.
Yeah, acute events.
Yes, and what is important to stress here, I know I am sure that you recall the Bechterew nystagmus, which is a very characteristic for the nystagmus which appears in case of complete vestibular deficit on one side, on the right side, for example. And if the subject develop a deficit on the left side, he will very very caricatural, in a very caricatural way, will develop an nystagmus to the reflected side, on the impaired side.
Right.
And this is very interesting to discuss, because effectively in case of vestibular an impairment, bilateral and episodic impairment, but not complete, we can assist at a picture, and a clinical picture as described by Art in his case.
But
you know, one other point I think is maybe helpful in this case, if he would have had some sort of documentation of his vestibular function back in 2015, it would be much more helpful to kind of help figure out what's going on now. And
absolutely.
You know, because I know there's a lot of folks that are not very much into doing any kind of vestibular testing, but you know, to me, a guy gets a bad vestibular syndrome and he's having problems for a year. I think he definitely would have warranted testing back in 2015.
Yeah.
In which case, when he presents in 2022, you have a little better idea what's new and what's old.
Yeah, exactly. If I'd assessed him, I would have done calorics in that as well. And hopefully in 2015, it's so a lot of people say, well, calorics aren't all that useful. Calorics are very useful for documenting pathology and also for characterizing it. If it tell patients, you put water in their ears, and if they, oh, this is the same kind of feeling that I've got, then they have a vestibular problem. It's so helpful to do that. There's some people who are so-called vestibular hypersensitives. Calorics just destroy them, so they can have relatively mild problems, but still be extremely symptomatic. And another thing, Jerry's probably heard this before, but I've heard ENT doctors say, if you want to get rid of a patient, just put ice water in their ears in your office, and guaranteed they'll never come back and see you again.
So I see we have a comment from Sarangi.
Yes.
If you're there, you want to, hey, Sarangi, do you want to make your comment?
Hi. Yeah, no, I mean, I don't know, obviously, how my practice compares with what's going on, obviously, in North America and elsewhere in the world. But I routinely, we have a very high volume of patients in my practice in London, and sometimes I just see the value of documenting normal results, because then, exactly as you've just said, you know, when they come back in the future, I don't know, in 10 years' time, whenever, you will always then be able to compare with what you've had, you know, a normal caloric, or, you know, then you can, I mean, this case perfectly highlights this beautiful case, and, you know, you're able to then see. Whereas here, there's also the value of, I presume this is the same V-hit, isn't it, Art? Like the right side and the left, so this is from the same. Yeah, so you can see the coalescing of the, you know, of the saccades, obviously, within, you know, these are obviously, you know, covert saccades. So that has been a compensatory process over time, right? So you don't, you know, now you're looking at one snapshot, you know, at some point in time, but it would be amazing to have been able to capture that earlier, wouldn't it? In the
absolutely.
You know, I mean, this is the value of even serial V-hits. I mean, we see the value in serial audiograms. And I remember being in one of Jerry's lectures previously, and he's kind of said, you know, the value of testing at different frequencies, etc. I mean, this is what I think we under-test, don't we? The vestibular system generally, because it's expensive. It's, you know, but this is the value. This is what we need to get out to the world.
Sarangi, I had a patient just recently that is the epitome of what you just talked about. He came to see me a few years ago, and he had a significant loss of function on the right side. I mean, like 60% caloric deficit, V-hits, everything. And then I treat him. He does great. A few years later, he presents with acute vertigo. Kind of sounds like Art's case. And now I test him. He's got balanced calorics because the other side came down.
Exactly. Exactly. Yeah. Normal calorics. It's
Fine.
exactly. Yeah. That's a very important point to make.
Yeah.
Wipe out
Yeah.
one
And from a,
side.
yeah, and from a
Yeah.
medical legal aspect, this is, I mean, this is just now you know exactly
Yeah.
what's going on, right? Whereas
Yeah.
if you don't have the testing, then you can't see that. So amazing.
Absolutely. Yeah. Very interesting points. Thanks. Thanks for your points.
Well, Art, great.
Jerry, yeah.
Yes,
Well,
Mo.
do you think that partiography would be helpful in this medical legal case?
Yeah,
Yes,
so
it would be.
I was going to make a little comment about that. What we did a study a long time ago where we looked at those with litigation involved versus those that don't, and then we just honed in on those with litigation, and they kind of broke up into three groups. You had 25% roughly where they had pathology, and the pathology pretty much lined up with their history. We had 25% where their history made no sense and they had a lot of non-physiologic stuff on their testing and nothing like really there. But then we had this bigger group, about 50%, where they had pathology, but they looked like they were exaggerating. And so you could kind of break it up and look at, you got 75% of folks that have exaggeration or malingering, or you could say you have 75% of folks with pathology, and you'd be right in both cases. So, in my mind, even though, obviously this guy has pathology, it doesn't mean he's not laying it on thick for the disability.
Yeah, that is,
But
that
in
is
my
true.
mind, it's like, as long as they're straight with their testing, I let the lawyers figure out how bad the problem is the way I put it.
Yeah.
But I was going to say, we're right at 11 o'clock, and unfortunately, I have to run. But it was a great discussion, Art, and I think our next
thank you.
discussion we have to get together and come up with the date. I think we'll probably wind up doing it the first week of December because we're going to be running into Thanksgiving over here. But great job, Art. Thanks for
thank
input
you
from everybody. Good to see you, Sarangi and Bulent and Morgan.
Okay.
Thank you all.
Thank you. Okay.
Thank you for this.
Okay.
Bye.
Okay. Nice to see everybody. Okay.
Bye bye, everyone.
Bye-bye, everybody.